This conference will now be recorded.
Hello, everyone, and welcome to the AnCan High Risk, Recurrent, and Advanced Prostate Cancer Support Group video chat for Monday, November 18, 2024. I'm Len Sierra. I'll be moderating today with a little help from everyone participating. And we want to acknowledge and thank our sponsors, and they are Bayer, J&J, Myriad Genetics, Novartis, Tix, and Blue Earth Diagnostics. I think, of course, we have to start with all of our new members. And I guess we can start with Roger.
Len, just before you start, because I want to get this in at the beginning of the recording, and for everybody who's here, if you have not yet filled out the survey, please take 7 minutes to fill out the survey. I won't embarrass everybody to see who hasn't done it, but as you know, we do an awful lot. Our volunteers are just incredible. We give a lot of time. We don't ask you for much, but we are asking you to complete this survey that will take all of 7 minutes. You've gotten a couple of reminders about the survey. It's been in the reminder, the meeting reminder, and the link is posted at the top of the chat, pinned to the top of the chat. So click it and you'll come back to it later, but we really we're not getting as good a turnout as we had hoped for. So please, and we'll keep pushing this right the way through the month into the first weekend. So please, because I will start asking who hasn't done it very soon.
Did mine, Rick.
Okay. Roger, could you raise your hand so I can locate you on my screen? There you are. Okay, Roger. So how old are you, Roger?
64.
Okay. And
I live in Richmond, Virginia.
Very good. And I think you heard about AnCan through Todd. Is that right?
Yes. Yeah, my cousin is very good friends with Todd. I think back from the high school days. And, my brother was talking to my cousin about my situation. And then all of a sudden he said, hey, there's this guy, Todd, who can relate. And he's a little further down the road. And I want to hook you up with him. So, I was fortunate enough to have a conversation with Todd. And he was gracious enough to say, hey, there's this group and love to plug you in. And it's called AnCan. And sure enough, here we are.
All right. Welcome to the group. When were you diagnosed, Roger?
It was last summer. So it was, it was summer of 2023.
And at that time, what was your PSA?
It was a 14.
14.
14.
And so you went to a urologist and they did a biopsy, maybe a scan?
Yeah, we the family plays a lot of pickleball, blah, blah, blah. It was hotter than hell in the summertime, and I must have drunk like 5 gallons of water. And, get home, and all of a sudden, I was having some of the typical, it takes a little while to urinate, and it's just in life in general. But man, all of a sudden that night, it's like, I can't get, the balloon is so full, I can't get it out the tiny hose. So I was up all night trying to figure out a way to drain my bladder, blah, 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 and the wife is like, hey, you got to go to a urologist. Because I typically have not gone to the doctor over my lifetime. I haven't needed to. I've been in great health and haven't had any major, surgeries, broken bones, blah, 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 even playing sports. So,
Roger, I'm sorry to interrupt, but we have so many guys to get through here. Let's stick to my questions and, further down the line, we can learn more about you. So what was your Gleason score?
I had two twos, a 3+4s, and a 4+3. I think is what he was telling me.
4+3.
So maybe it was, yeah, a 4+3.
Very good. And what was the primary treatment? What did you have? Radiation, surgery?
No, surgery. He did the robot.
Okay. And when they did the pathology report on the prostate after they took it out, you were still Gleason 7, 4+3. And
Yes.
yes. And they thought, did he say, I think I've got everything, or were there any positive margins?
Well, I mean, I was asking him for like, please leave me some margin, please, kind of thing. And I kept reiterating that. And he said, if I get in there and I look around and I check the lymph nodes, and if I see anything that looks like it needs to come out, I'm going to take it. I'm like, okay, that's fair. But yeah, I think he left a reasonable amount of margin. But ever since then, my PSA has been rising again.
How soon after the prostatectomy was it rising?
Within the first couple months. Because
Okay.
it was the first time we measured it after the December surgery, it was already at 3. And he's like, maybe it'll settle down. Then a couple months later, I'm at 5. Then the next time I go in, it's like 0.55. So.
Oh, wait,
And then
wait a minute. First you were saying 3 and 5, and now you said 0.55.
Oh, sorry. Yeah,
So
yeah, sorry. 0.3, 0.5, 0.55.
Oh, okay.
Yeah, sorry.
All right. So did they do salvage radiation, or what happened next?
No. He sent me to the radiologist. They did a PET scan again. He couldn't see anything, but he says, hey, I'm going to put you on hormone therapy and radiation. And I'm saying, what? You can't see anything. You're going to what? So I just said, this doesn't feel right to me. So I went back to the urologist, the surgeon, and said, here's what he told me. Like, there's got to be something else. And he said, okay, we're going to do a Decipher test. So they did that. And and I'm low end of high risk.
What was the actual score?
You know what? I don't know.
Well, okay, so you're low end of high risk. So what did they decide to do? Did he freeze or did he die?
Are you still with us, Roger?
Oh yeah, I'm here. I think it was a 6.5.
Okay, so what did they decide to do next?
They're waiting on me. I just said I'm just not sure. I said I need to start doing my own homework. I think they would just love to jump into the hormone therapy. Lupron has come up, and like 7 weeks of radiation every day, Monday through Friday, and I'm just saying, hey, what the hell are you talking about? So I don't know.
So you haven't had anything since the prostatectomy?
No.
No. And what is your?
They've wanted to do it, but I've just been hesitant because they've got this road, and I'm going, I don't know.
All right, listen. What was your latest PSA, and when was it?
The latest one, but it came out of a different lab. So this was with my primary, my PCP. She said it was 0.9.
Okay.
Yeah. So I'm due back to the urologist and sort of figure out.
Just so you know, what they were suggesting for you was actually the standard of care. Once your PSA exceeds 0.2 after a prostatectomy, the standard of care is to get salvage radiation therapy. In your case, maybe not hormone therapy, or if they did have hormone therapy, it would be short course. So, I mean, they weren't way out of line suggesting that to you. And now that you're at 0.9, I'll open it up to the guys here. I would suggest another PSMA PET scan, but I'll open it up to everybody. Anyone want to comment?
When was your surgery? The
December 23.
12/23. Okay.
So almost a year ago.
Okay.
Where are you being treated?
Virginia Urology, Stony Point.
Let's see who. Jeff Markey.
Yeah, are you still just seeing a urologist?
Yes. He introduced me to the radiation oncologist who, read that second PET scan. And he's the one that said, okay, even though I can't see anything, I recommend, this and this.
Well, it might make sense for you to see a genitourinary oncologist. I'm surprised Wick didn't jump on that because he usually does. You want to get an expert, and you don't work with a urologist once you're having recurrence after surgery. The urologist is a surgeon. He is not a prostate specialist.
Jeff, what he should be seeing right now, he doesn't necessarily need a GUMO. He should be seeing a radiation oncologist, which he did.
Except he won't listen to him.
Well, so that's really more the problem. And we have another issue, which is Richmond, Virginia, you don't have a lot of great choices in terms of radiation, in terms of GU medoncs. We don't care for the guy at UVA, although there is, and I'll tell you what his name is in 1 second. If we thought he was a good guy, we might send you to him, but we've not had a great experience with him. There is a urologist who's really good at UVA, and she could give you a second opinion on how to follow up, and she knows us well. Her name is Kirsten Green. She's actually the head of the group there. Dreiser, the guy that we don't like is Robert Dreiser.
Got it.
If you were to go further afield for another opinion, we might send you to the team that treats George Wesolowski, who's on this call right now. They are over in North Carolina at Duke. There is a guy, I always forget his name. There's a guy in Virginia Beach, but again, it's not a center of excellence, but he's not bad. He's not great. He is a GU medonc. I'll tell you his name in a second. Rich Jackson. What's the name of Rich? It's Michael something or the Mark Fleming. So
Mark Fleming in Virginia Beach, Rick?
Yeah, Mark Fleming in Virginia Beach.
Okay, thank you.
He's in a community practice, but he's very well. He's well held. He's not very flexible. He's not the sort of guy that you can have a discussion with. Which we don't love. Even though she's still a urologist, she's not going to be treating you, but just for a second opinion, I think Kirsten Green might be a good option. just because of where you live. Just
Okay.
not sure if anybody's got any other suggestions.
Anybody in the DC, Northern Virginia, Maryland area,
Um,
Hopkins or
yeah, if you don't mind driving up there, Channing Palla. I'll come back to Mark's Jeff March's suggestion. Channing Palla. She's a GU med onc at Sibley, and you could talk to her. We used to have a
She's taking
outstanding.
patients right now.
What's that?
She's taking patients right now.
She is taking patients, you're saying?
Yes.
Okay, so she's a good option. The other thing is to go talk to another radiation oncologist.
What about Danny Song in John Hopkins?
Don't know him. Danny Song?
Yeah, he's a radiation oncologist. He's a big head there. Dr. Danny Song.
Is he in Baltimore or is he at Sibley?
Baltimore. I saw him.
Yeah, I mean, again, that's a bit far, but
yeah, but that's okay. You know,
we've got other folks who are at got other folks also we could recommend at Duke. There is another radiation oncologist at Sibley, an Asian guy, not at Sibley, at Hopkins. Our guy we really liked picked up and went to work with his brother in Tampa. We had Go ahead, Captain Jim. Sean
Collins.
Sean Collins. Sean Collins was the guy, and that would have been our first choice above everybody. But
he's in Tampa.
He's left now. I think he's gone to work with his brother in Tampa. He was at Georgetown.
Yeah.
When was your last PSMA PET scan?
I think it was May or June
of this year.
Yes.
Right. Well, the thing is, like Len said, usually at point 2, you go to salvage radiation because while the cancer may not be very big, it may not show up in a PSMA PET scan. Not all of it does. Your chance of having it come back is really high, and you really want to get on it when your PSA is up at 0.9. It's radiation and the ADT. You might be able to avoid ADT if radiation brings it back down, but you need to do something. You just said a 4+3. You're that's an aggressive cancer. It's not real aggressive, but it's aggressive, and your Decipher score isn't good either. So you don't want to get metastasis in multiple places. You want to do something before that happens. Let somebody else talk.
Okay. Thanks.
So Roger, did you have any questions that you wanted to ask the group that haven't come up yet?
What about, so let's say I just go down the route that they're talking about and it's the radiation and or the ADT at the same time or however they do it. Is there, I mean, I hear just out, like ivermectin has had possibilities, fenbendazole that Todd was mentioning. Like, is any of that, can I put my weight on that, or am I really dealing with either the ADT and the radiation? Like, I guess what I'm asking is, am I stuck over here no matter what? And then these other things I might do might help me a little bit, kind of thing. I'm just trying,
Len, why don't you respond to that, please?
Yeah, in this group, Roger, we can't comment on or speculate on therapies that have not been proven in clinical trials, and both of those chemicals you mentioned have not gone through human clinical trials and shown, they may not have gone through them at all, or if they have, they haven't shown efficacy. So that's not something we would comment on. Our role here is to make everybody aware of what the NCCN guidelines would call for, the basically the standard of care for a particular situation.
I mean, I might go one, Len's being very diplomatic, and I don't want to offend Todd, but in all the years that I've been doing this, we've never seen a benefit from ivermectin or fenbendazole. And some people do it. They think they get a benefit out of it. And if they do, God bless them. We would never suggest that they do it, but they can go ahead and do it. If anything, it's complementary and alternative. And what you're not going to get away from is the fact that you probably have to do some radiation and some hormone therapy. And if you don't do it, you'll get yourself in a bind, and you don't want to find yourself with metastatic disease. Now, I would definitely say get another PSMA test as soon as possible if you've risen to that level. And it might be possible that they could do some spot radiation if they see where this is coming from, see where that goes, and delay the other issues. But even that would not be standard of care. So, I think that in your case, that's what you got to face up to. That's what we would say here. And I don't mean to offend anybody on the call.
Understand. Listen, I get it. I'm just exploring all the options, and if there's a way not to do that shit, then I want to do it. But if that's just the way it's going to have to be, then so be it. Then I'll get on it. So I appreciate that. Thank you.
The only way to avoid it, and I would say to defer it rather than avoid it, is if you're a candidate for some spot radiation. And we've seen people do that, and it puts it off. But at this point, it rarely nails it altogether.
Okay. Got it. Okay.
Thanks, all right. Okay with you, Roger, if we move on?
Oh, yeah. Good to go. Thank you.
Any genetic testing, Roger? Have you done any genetic testing at all?
Just the Decipher test, right? Because that's...
Right. Have you... do you have any cancer in your family?
Yes.
Can you tell us what it is?
Dad had prostate and colon cancer, but he lived to be 87. I mean, that's a good life, you know?
Okay. So yeah. I'm going to put a link in the chat window for you in a second called the PROMISE trial. And it tests to see if you have any inherited mutations. There is a link between prostate cancer and colon cancer. And I think we should be ruling out that that is not your situation. Probably is not, but we definitely need to be ruling it out. Okay? The PROMISE trial is run by Johns Hopkins and University of Washington. It's a test that's conducted by color. It's very much above board. They'll send you a kit in the mail. You do a mouth swab, send it back to them, and then they'll call you with the results or send you the results.
Wow. Okay.
Okay. You don't need to run it through your doctor, although some of the guys who have done it here say be sure not to click that tests are sent through your doctor.
And we forgot to mention, as we usually do with new fellas, diet and exercise, very important with prostate cancer. This has been proven to be helpful. So are you good with those two areas of your life, your lifestyle? Roger?
You guys talking to me? Sorry, I lost you for a second.
Yeah, diet and exercise. Are you good with that? or do you need advice?
Maybe just diet, exercise. I'm good.
Exercise,
Okay.
good, yeah.
So come back next week because we're really pushed. We'll talk.
Sure.
We meet every week. Come back next week, and when Dr. John asks if you need time, say yes, and that you'd like to talk a little bit about diet, and we'll help you out.
Okay, perfect. Thank you.
All right, thanks, Roger. See you next week. And Michael, since we don't have your last name typed in there, I'm just going to say Michael Italiano. Go ahead. When were you diagnosed?
I was diagnosed in 2022.
Yeah, we need more volume at your end, Michael.
Let me see if I can. Is that any better? No, it's not working better.
All right, I think this will work. So
if I speak like this, is this okay?
Yes.
Good.
Looks like you have to be close to your mic there. Okay.
Yeah.
So when were you? First of all, how old are you, Michael?
I'm 61.
Okay. And where do you live?
I live in Woodstock, New York.
Okay. You're too young to have gone to the festival, so I won't go there.
Yep.
But let's see. When were you first diagnosed?
It was 2022, in the fall of 2022. PSA is 17.
Sorry, what was the PSA?
17.
17. Okay.
Did a PET scan, didn't see any metastasis. Went to
Was it a PSMA PET scan, Michael?
Yeah, PSMA PET scan. There was no metastasis. Went to Memorial Sloan Kettering, had high dose brachytherapy, and then 5 sessions of radiation therapy, the high dose radiation therapy.
Yeah, SBRT.
Yeah, that's it. Thank you for helping me with that. I'm not going to remember all the names.
Yeah, that's all right.
I did have a deciphered genomics test. It came back at 3.9.
3.9?
Yep.
Which is low risk, I think, isn't it?
Yeah, it's on the lower end. Yep.
Yeah. So, can you tell you what your Gleason score was?
It was 3 plus 4.
3 plus 4, okay. It's favorable intermediate risk. Good check there. And so who did your radiation at MSK?
Who did it?
Who did your radiation at Sloan Kettering?
Sean McBride.
Oh, yes. Okay. And when was that done?
That was done in December of 2023.
Okay.
Well, maybe actually December of 2022.
22. Okay.
Yeah. Yep.
Yeah. And so what's happened since?
My PSAs were good. Then I got a bump to the PSA of 5 in May, and he attributed that to the possibility of rebound effect associated with radiation therapy.
Right.
And I had my PSA checked in October, and it was 17.
8?
17.
17 again. I thought, wasn't that your original PSA?
Yeah, that was my original when I first went to the doctor. Yeah.
And so then
before the biopsy.
October of 2023, it was 17 again.
October of this year.
Oh, this year. Okay. So who have you been seeing? A medical oncologist at Sloan Kettering?
Yeah, that's where I'm looking for some advice here. is that, you know, now I'm trying to move so you can see my face. There we go. So yeah, so I went in last week, had the PET scan, the MRI, and all the things like that. I'm getting referred off to a medical oncologist. If there's any advice of the group here about medical oncologists within the MSK system, that would be great. Right now, I'm checking right now to see who my appointment is. My appointment now is with Karen Audio.
Aha.
Yes,
Aha.
we had one of our members is seeing.
Where's our man? Where's our man? Hello. Hello.
Is this good? Is this good or bad?
This is
Well,
good, according
we'll
to
have to
Larry.
let our man respond to you. Go ahead, Larry.
Well, all right. What I want to say is that. Oh, can you hear me?
Yeah, I can hear you.
Okay. Yeah, I really like her. I've been diagnosed 8 years ago, and I did go through radiation a couple of years ago with Sean McBride. I'm more advanced than, considerably more advanced than you are, and the thing I really like about Karen Audio is that she answers every question I have, and she's willing to discuss, especially since I've been going to this group for many years. So I know she knows when I talk to her that I have a lot of good ideas, and she's very responsive. And I like her. I don't know if she's the best possible oncologist at Sloan. I know they have a couple of superstars there. I don't know if you can get to see them. So I'm very happy with Karen Audio. I don't know what happens at Sloan. If you see her and then you want to see somebody else, it may not be very easy to switch. So
Yeah.
how did you get to Dr. McBride? Where did you go before that? Did you end up?
I went to a urologist up here. They referred me to Sloan Kettering, and Dr. McBride was the next guy in line, and that's how I got him.
Yeah.
And now, you know, when I spoke to Dr. McBride, I said, you know, I'm not interested in the next oncologist in line. I want to have the opportunity to speak with an oncologist that realizes I'm going to be a little bit of a pain in the ass.
Oh, well, I don't know if I would approach her that way, but
no,
she's very I'm
Great way to
a bit of a
advertise
pain.
yourself.
Well, I'm a bit of a pain in the ass.
What I'm trying to say by that is that,
yeah, I know.
You know,
I understand.
You know, we all know that when we go into this medical system, we have to dom the medical system. We have to get things and have them do things the way that we want them done. And some doctors respond to that better than others. So, you know, I'm interested in someone who's going to listen to me and so forth.
So
yeah, she's very flex. Okay, go ahead.
I'm just looking at the time. Okay. And I know Len's a bit pushed. Let me throw out one other name, because there is a superstar there that should be pretty easy to get to, and you can check Karen Audio and check this other name. The name is Chuck Ryan, Ryan. He was the former chief. He was the CEO of Prostate Cancer Foundation. Before that, he was at University of Minneapolis, of Minnesota in Minneapolis, and before that, he was at UCSF. I know him very well. He knows me very well. He knows AnCan very well, and he started his practice at MSKCC in October. So he should be easy to get to. He is the doctor who was the principal investigator for abiraterone, which is now a very, very well used drug. I don't want to say anything negative about Dr. Audio, because I cannot. and she's taking care of Larry Fish very, very well. We have other docs that we like, but I'm just thinking that if Chuck has space, he's very, very, very experienced.
Okay, thank you for that. Because when Sean asked me who I wanted to see, he said, would it be a male or a female? I said, I don't care, just whichever one's going to fit my personality best. So that's how he mentioned her. But you know what? I'm going to find out. I want to see both of them. I got good insurance. I want to talk to both of them.
You will not be able to do that. Let me save you.
Thank you.
Okay, let me save you spinning your wheels.
Yeah, thank you.
What happens at Memorial Sloan Kettering most of the time is whoever you get is who you have to stay with. It is very, very hard to switch. You won't be able to see both of them. We can give you other names in the New York area, but they won't be at MSKCC.
Okay.
So once you get into bed with one of these docs at MSKCC, you got them. Now, what I would do is a little of your own homework on Dr. Audio, a little of your own homework on Dr. Ryan. Dr. Ryan is very knowledgeable. He's Midwest. He's very nice, very charming. He's very smart. You can talk to him. So he'll absorb your New York manner, and if he doesn't, you tell him to call me because he better learn to do that pretty quickly. And I'd be happy to tell him that. I actually mentioned that when I heard he was going there.
I will check in with them tomorrow and make arrangements to see Chuck Ryan entirely based on what you just said. Thank you.
Well, I don't want to offend Larry.
Larry?
Larry Fish, who just spoke to you.
Yeah, no, I'm not offended. I'm very happy with my doctor, and I haven't thought about switching to anybody else.
Yeah, I mean,
okay, well, that's the whole
I
thing.
have no offense. I think you should,
okay,
see the best person you can get a hold of.
I mean, it's just that you've got a really, really highly qualified doc. And the reason he's easy to get to is because he just moved his practice. He just moved there when he left.
So I could get on his list because
I'm pretty sure. And if you couldn't, I just need to drop him a line.
I'll do that tomorrow.
Okay. Now, do we have you registered with us, Michael? Do we have your email?
I hope you. Yes, I think you do. Yes.
Did you get a reminder for this meeting?
Well, if I would have checked my emails, I may have noticed, but I didn't. So,
for good order's sake, stick it in the chat window. You can send it to me alone if you don't want to send it to everybody.
Yeah, I mean, really, it's almost, you got to text me almost in order to get a hold of me.
Okay.
But anyway, I'll pay attention.
Okay.
So I'm off on this journey, and we'll see how that goes. Thank you for your help. I mean, this group is invaluable.
Okay, and have you done, same question as we asked before, have you done any genetic testing?
Yeah, I had to decipher, and it was like a 3.3, 3.9.
What about for inherited mutations?
No.
Okay, well, that PROMISE trial is in the chat window. Click on it. And do you have cancer in your family?
Yeah.
What cancer do you have?
My father had pancreatic cancer, and 3 of my cousins all have prostate cancer.
Okay, well, definitely get that. We want to rule out the fact that you don't carry a BRCA mutation, especially if your dad had pancreatic.
How would this help me?
It opens up. It helps you in a whole number of ways. If unfortunately it turns out you're BRCA positive, we've got to have you checking for a whole bunch of other cancers. And it opens up certain treatments for you that are not available to people who don't have that mutation.
Okay, so you don't want to find out that you have it, but if you do have it, there's options that will make it better. And that's better than not knowing you have it and not testing for it. Got it.
We would definitely say that you should know, you should test the if, since your cancer's returned, the standard of care is that they test you. Standard of care may also be, if they see metastasis, to see if you've made any mutations yourself that you didn't inherit. So you may need a second test, and somebody like Chuck will make sure you get it. But in the meantime, you can do that promise trial right now.
All right, so Chuck would bring this type of thing up to me.
Absolutely.
Thank you. That's all I need to know. Thank
Don't,
you.
don't even wait on the appointment. Get the promise trial right now. There's no downside to that. It doesn't cost you, and it's helpful information.
All right, well, you've given me two things to do tonight. Thank you very much.
Okay.
All right,
Michael. I'm John. I'm another one of the moderators. I just wanted to ask Michael for his last name or initial because I got so many Michaels.
We have it. I'll send it to you, Dr. John.
I'm sorry. I didn't type
Thanks,
it in.
Rick.
I didn't think to do that.
Don't worry about it.
You don't have to do that.
But what I do want to make sure is make sure we have your email so that you're on our mailing list. You can do it on our website. You can give it to us here, but make sure so that we get to you and we can connect with you, especially if you want me to drop Chuck a line.
Yeah, I will do that. Thank you very much.
Okay.
So Rick, how are we treating Luther and Bob Peftal as far as new members concerned?
Well, Bob Peftal has been with us before, so it's just a question.
All right.
You just treat him as if he has a question because he's already been through this process with us. And Luther said that he just, wanted to sort of listen tonight. So given that it's we're on the hour already and you got a bunch of people, I would say Luther should. Dr. John, if Luther comes back, and we hope he does next week, he gets priority as a new man.
Very good.
Okay, so we will now go to Dr. Jeff. Yeah, there you
Okay,
go.
so I just want to relate a brief story, and you can draw your own conclusions. Me about a year, close to a year, to get my original urologist to forward my records to the GU oncologist that I currently see at Sloan Kettering. They sent me the records. The oncologist shared my records with me, of course, and I wanted to see what was written in my records by that initial provider. And I read of the 3 rectal exams he did on me over the months that I saw him, in very detailed descriptions of what my prostate size was, how my prostate felt, etc., when in reality he never performed a rectal exam on me.
Oh dear.
Yes. So again, 3 descriptions, 3 separate visits, and it never happened. My point is, read your records. I've said this many times. Read your records, make sure they're accurate, and if they're not accurate, make sure they get corrected. This happens a lot, and doctors, I've been a physician for almost 50 years, and I know what my colleagues do, and they're in a rush, and they're backed up, and they just, maybe they don't remember or whatever the reason is, but they fudge things. It's unfortunate. That's reality. Again, look at your records, read them, and if you don't understand them, get somebody to explain them to you. That's all I have to say.
And Jeff, you might want to add to that. Was it someone else's record that you got?
No,
Yeah.
no, they were mine
Okay.
because I had a resume procedure along the way and it was in there. So they were definitely mine. They were just uh, falsified.
Mm-hmm.
Well,
That's
Could he,
worse.
could he, could he have been covering his ass?
Possible. It's possible. He did it 3 times.
That's pretty bad.
Sure
Yes,
sounds like
terrible. So my lesson to share with everybody here is make sure it's not happening to you.
So, I mean, it could, of course, have been in your records and somebody else's DRE that he got confused about.
3 times
Especially
is a lot of confusion, Rick.
so, especially, but what I'm, what I'm worried about, I like Commander Adams' comment in the chat window. Definitely wasn't covering your ass. Okay, good one, Adam. What are you going to do about it? I mean, how do we stop this as from a patient standpoint? You have to take your physician's hat off here. As I'll say, Jeff. Well, I would say Dr. Jeff. Well, Jeff, yeah, from a physician, what do we do? What do we do as patients if we see something like
Okay,
this?
so the first thing I did was consult an attorney who went over it in detail, and he said, I really wouldn't want you to go forward because I don't think you would win anything in terms of a lawsuit, even though the guy cost me 6 months of not getting treated. But there is an office in the state of New York, and I kind of think they exist elsewhere, the Office of Professional Misconduct, OPMC. They take every report. If you call them and tell them what you think is professional misconduct, they take the report and they usually investigate it. I think that's about all that I could do is make a report to the OPMC.
Mm-hmm.
It's disgusting. It's disgraceful. But it's kind of the way medicine has migrated in these days.
Oh, man. Unbelievable.
Yeah,
Unbelievable.
sorry to hear that, Jeff. Thanks for sharing it, though. Hopefully it'll.
Len,
Can I
help
say a
others.
word, Len?
I'll make a more generic comment. I think as physicians, we have an obligation to tell all of our patients to get their record, to sign into the patient portal. I've been telling people for years, if you have any kind of imaging study, ask the technician to make you a CD and don't leave without it. And so, okay, sometimes they can't make it right then. We'll mail it to you in a couple days. Fine, you have to give it sometimes. But really counseling our patients to be on top of their records to the extent they can. Now, Jeff's urologist probably just wasn't cooperating with repeated requests. That's a different problem. But if every patient said every time, oh, great, I'd like a copy of my notes today. And with the modern, EMRs like Epic and so forth, that's easy to do. It's a click of the mouse.
The big excuse, though, that's given is we farmed out our records. We don't have them here. We can't make you copies. It's a third party that's doing it. You have to contact the third party, fill out this paper, blah, 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 which I did. And then when I didn't get them for a month, they said, oh, you never filled out the paperwork. I said I was right here. You are the one who handed it to me. So, look, we know medicine today isn't what it used to be, and the level of caring is unfortunately lacking. So we have to be our own best advocates. And like you said, we have to push for our information, review it, make sure it's correct, and make sure we're getting the right treatments.
Yep.
Okay. And Jeff, as I recall, this urologist gave you other bad advice regarding your PSA, watching it rise and telling you not to worry about it. Do I have that correct?
Oh, he guaranteed me I did not have cancer on multiple visits. But the reality is I did have it. I'm being treated. And, it's I'm sharing this not because I can do anything. I just don't want someone else to run into the same situation and find out that they don't have accurate information, or that doctors are saying they did things that never happened.
Len, Mary Jo has her hand up.
Oh, sorry. Go ahead, Mary Jo.
Now, I agree with you. I worked for a group of orthopedic surgeons for 23 years, and there were mistakes made. And the patients, if they did get their records, they would call up, and I wound up making addendums to the charts, but I had the charts, on hand. But I was just at the cardiologist, and I just went over my records, and I have 5 cardiac stents. And in the notes, he says, I'll see her on a PRN basis. Now, I have to go every year. I mean, I just can't not go because I'm on all this medicine, Plavix, aspirin. That's the first time I noticed that he did that. So I'm going to have to call the office myself. But you're right, mistakes are being made a lot. And I think it's a format, too, that they call in, because we all had, like, for a hip x-ray and a hip exam, it was, they would push a button or say something, regular hip exam. And I think that's what's happened. Like in the plan, everybody gets the same plan, and it's wrong.
It's wrong.
And they're not checking it.
All right, Mary Jo, thank you for that. And thank you, Dr. Jeff.
Len, can I just ask if anybody needs to, we may have to run over. If anybody has to leave early, please let Len know in the chat so that he's aware, because we don't want you dropping off if you've got a question and we haven't gotten to you and it gets to the top of the hour. And the other thing is, again, I'll say, please scroll up to the top. And if you came in late, and please be sure to fill out the survey. It will help us.
Richard Fisk, did you intend to send me a message? Oh,
yes, I did, and I'm in the process of completing it. I'm just saying, if you run over, cut me. I don't have to be up tonight.
Oh, okay. All right. Well, let's get moving so we don't have to cut you. Tom Hoffman, go ahead. You're next.
Hi. My camera cut out, so I'm probably, I think, the only black space on the screen. So I apologize for
We
that.
see you. Go ahead, Tom. You're fine.
Yeah. My question is related to exercise. Is there any requirement to get your heart rate up to a certain speed in order to get the benefits, the mitigation of fatigue benefits?
Rick, you want to take that?
Well, if Jimmy defers to me, I will. I have to ask Jimmy first.
Oh, all right, Jimmy, go ahead.
You've never asked anyone to defer to you in your life, mister. You go right ahead.
Actually, I'd rather defer to Jimmy. Go ahead, Jimmy.
Go on, Jimmy, and then I'll add anything because I have some thoughts.
Okay, now I was away for a second, just came back. The gentleman wants to know if there's a certain form of exercise that will knock out the fatigue. Is that the idea?
Yeah, I mean, is there? Yes. Go ahead.
Okay, so we would all like to get the most bang for the least amount of effort. That's what life's about. That's what exercise is about. If we can get the most reduction of fatigue with the lowest possible effort, I'm joking, but that's kind of intrinsically what we're all kind of after. I think it depends on what kind of exercise you're doing. Really, if you're healthy enough to handle it, high intensity exercise, short duration, has an almost magical effect on fatigue, I think. If it involves some resistance training, that's great. It's simply a matter of not taking much rest in between. You can combine different movements in a weightlifting or calisthenics kind of program where you're not, the typical gym thing where you're sitting and resting and looking at your phone for 3 minutes in between 10 reps or something. That's okay. That's a waste of time compared to what you can get done in a short amount of time if you try. And on the other hand, if you're doing cardio, sure. One of the best things I ever did when they started going out was to get a heart rate monitor and monitor my heart rate as I exercise, so I know that I want to be at a certain range. But you can get just as much out of pushing it really, really hard in intervals of a minute, 2 minutes, 4 minutes. There's different programs. And with equal amount of rest in between, you maybe do 4 sessions of that. It might take you 25 minutes, 20 minutes. Or you can do long, slow for 45 minutes to an hour. And the only thing that's hard about the only caveat about the short duration, high intensity is it really sucks. It's really hard. It's really difficult. But both are great. And I think that the bottom line also is the more sedentary, the more unfit you are, the more out of shape you are, the better and faster results you're going to get. So there's always that bang for the buck is really always there. The further down you go, the faster you're going to improve, the more improvements you're going to make. Should always be encouraged just to know that.
That wasn't his question. His question is what his heart rate should be. He's not getting it over about 110. He wants to know if it should be 120, 130 in order to get good results.
Oh, I see.
For me, I can't get over 108.
Yeah. Well, you want to get, technically between 70 and 85% of your maximum heart rate. Your maximum heart rate is very loosely defined by 220 minus your age, but there's better ways to calculate it. But even if you calculate it like that, if you're in that zone, which, how old are you, sir?
I'm 71, and I'm on propranolol, and that has significantly reduced my heart rate. I cannot get my heart to beat faster than 105, even with maximum exertion on the machines.
What type of medication is that?
The beta blocker.
Let me cut in for a second here. Oh, unless Jeff wants to do it.
It's a beta blocker.
It's a beta blocker. Your rate won't go higher.
Yeah, your rate will not be able to go up.
Don't go by the 85%, 75%. Just forget about that. Just work until it would be hard for you to recite a poem or something like that.
I'm so sorry that I didn't know that part of it.
If you can't really talk fluently, then you're probably working hard enough. And don't try for target heart rates with beta blockers.
Absolutely. Thank you, John. I didn't know. And that if you can sing, but if you can talk but can't sing, that's supposed to be the magic also. Yes, definitely. If they're on those drugs, yes, completely different situation.
All right. Thank you.
Okay, Jeff, I interrupted you, but did I cover it?
Yeah. But Jimmy, I have a question for what he said. Despite the fact that he cannot get his heart rate up because of the medical blockage, would not there still be benefit for his bones to do the walking in the absence of being able to increase his heart rate?
Oh, absolutely. Absolutely. It doesn't change your approach. You just have to monitor yourself a little differently and don't think of your inability to gain heart rate as anything more than a side effect of the drug. And you still, yes, do the work, do what you can. Yeah, it's essential.
Okay. Yeah, unfortunately, I can't really walk too well. I had a tumor in the femur when they first diagnosed me, and they had to put a titanium rod in my femur. And the recovery has just been horrible on this. It's 5-6 months ago, and I still cannot walk without a cane. It's just too painful.
Sorry. Can you bike or swim?
An exercise bike. Go to the gym. Use a reclining exercise bike on the lowest level of resistance.
Yeah, that's what I've been doing is an exercise bike and an elliptical.
Perfect.
Okay, well, thank you very much, gentlemen.
Okay, Tom, you're welcome. And we'll go to Bill Lee next. Go ahead, Bill. Bill with us?
I'm here. I'm
One
Bill
second,
Yu.
just 1 second. It's not Bill Lee. It's Bill Untied.
Yeah.
You got the wrong Bill. Go ahead.
Oh,
Bill
okay.
Yu.
Bill Yu.
Oh, I'm sorry. Yeah, again, my eyes, I can't see. Go ahead,
No
Bill.
problem. Very quickly, all I have is my promise results. So we did not find an increased risk for hereditary cancer in the genes we looked at. So that's all.
Excellent.
Okay. Very
Yes,
good.
very happy with that. Thank you. Thanks for recommending the promise trial.
Pleasure. And Dr. Alfredo has to skip out early.
Oh, okay. Dr.
Yeah, I was just going to
Alfredo.
tell one quick story out of left field. Sometimes in this group, I don't think we very often talk about healthcare economics and all the oddities, maybe because it's so complicated. So I'll just tell you this one story and then I'll sign off. I was supposed to get my first radiation treatment at MD Anderson, the first of 43 sessions, not this last Thursday, 4 days ago, but the week prior. And about 36 hours before that treatment, I got a phone call from somebody at MD Anderson Cancer Center, a very nice and competent young lady who said, this is really odd. Your insurance plan has denied your treatment. I'll just pause there and let that sink in. Your insurance plan has denied your treatment. What are you talking about? This is like telling me to drive from Houston to Seattle and calling me in Portland and telling me to turn around. She said, well, I understand that, but they've denied your treatment. Anyway, the good news is it's kind of straightened out. Today I actually had my third radiation treatment, and it's not at MD Anderson, although it's following the MD Anderson's instructions. It just happens to be in a building about a mile away at the multi-specialty clinic where I get most of my care anyway. So I'm not unhappy in the end, but I'll just leave to your imagination the stress that went on for about 48 hours after that phone call. That's all I wanted to share.
Did they deny your treatment because MD Anderson is not one of their providers? Your payers providers?
MD Anderson can be a provider and can be considered in network if they're providing a service that cannot be provided by the multi-specialty group. So 25 years ago, when I worked in the group practice myself, we didn't have a radiation oncology department. And I simply was not aware that today, 2024, they do. They have 6 rad oncs. They have the equipment in 3 locations around the metropolitan area. I've already met with the department chair. He's going to be my attending oncologist. It's fine. But it was a pretty stressful weekend.
I bet.
And I have no idea what the list price would have been for 43 radiation oncology treatments. So I'm glad it kind of got straightened out. For a while, I was thinking, okay, I'm going to proceed with MD Anderson and they'll be sending me a bill because it's out of network. But it seems to be all worked out now. That's it. I've used up my 2 minutes.
Okay. I think those radiation treatments would be something like 20,000, but I'm not sure.
Yeah, each. Yeah.
Paul Frieda. Thank you, Alfredo. Paul Frieda, you're up.
Okay.
Is Paul with us?
Can you hear me?
Ah, there you are. We can't hear you. We always have this problem with you, Paul. You kind of solved it. Well, start shouting and let's see if we can hear you.
Can't hear me. How about now? Can you hear me now?
Maybe some guys. Yeah, not very good for me.
Hear me now. Hear me now?
It's
Sounds like the end of a very long tunnel far away.
Far away.
There's something wrong.
Can you hear me now?
We can hear you, Paul, but there's something. It's very faint. Like a little bit better. Like on a scale of 1 to 10, you'd be around a 2.
At best, we need a new mic.
You can't hear me.
We can
That's not
hear
bad.
you
We
better
can hear
now
that.
than before. Whatever you're doing, turn it up to full on that.
Yeah, it's all the way. It's all the way up. It's all the way up.
Okay,
All right, just stay close to the mic and start talking. Go ahead.
Stay close and
All
keep
right,
talking.
let me try. I had a 5-year remission from 216 to 219, and no, actually, it was from 219 to 220 until last December. You hear me there?
Yep.
Okay, and so this year my PSA went from 0.13 to zero point 0.5 last week. So I'm starting back on Lupron, and my doctor thinks maybe I'll do it for a year and then I might be able to get another remission. I don't know.
What about, was there any discussion of adding an androgen receptor blocker to that?
He did suggest that might be something to do, but we want to see what happens after I just do Lupron, and maybe the Lupron is just enough. The other thing is that on the insurance, when I had my 5-year remission, I had Mutual of Omaha, so I never paid anything when I went in. But I switched to Medicare Advantage Humana, and they wanted me to pay $450 for my shot, and then I said, gee, that seems like an awful lot. So they said, well, if you send your 1099s to the pharmacy at Humana, they may give you a discount. And it turned out I'm getting a 70% discount. So I only have to pay about $135 for every 3-month shot. It might be useful information to other people.
Okay, well, everybody's different in terms of their financial situation and what they might have to pay. But I have a couple of thoughts here. First of all, you did a PSA at 0.3 and it didn't show a result. I think you need to repeat that PSA. Now, PSMA, I'm sorry. You did a PSMA at 0.3. It didn't show a result. That PSMA should be repeated, whether at 0.5, but before if you've had a Lupron shot, it needs to be done very, very quickly. That's the first thing. I mean, I wouldn't just stick you on Lupron because you didn't see anything at 0.3. That's not good practice, number one. Now, number two, you will see a result from the Lupron. It'll drive your PSA down. But the problem is that we know that best practice is you should be on 2 drugs, not 1. So you'll do it for a while, you'll get off, but what we're trying to do is give you the longest life and the best practice. And the best practice for somebody like you, where seems like it's come back after all these years, arguably, if we see anything on the PSMA scan, is to add a second drug. If we don't see anything on the PSMA scan, which is, I think, the situation right now, yeah, you could go on, he could put you back on the Lupron. But that's like putting, in my view, it's like putting a blinder on and saying, well, I don't see anything, so we'll just stick you on Lupron. I'm interested to know what the other people in this group say.
What's the other drug I should be taking?
Well, one of the second line ARSIs that we talk about here all the time, either abiraterone plus prednisone or one of the Ide brothers. You know, what we discuss here all the time, that most people are on.
Enzalutamide, apalutamide, or darolutamide, any of those 3. Also, another benefit to doing a PSMA, again, Paul, is they may find that you have one lymph node or two in your pelvic area. They can just do spot radiation,
Right.
and you may not need to go on Lupron at all.
That's right.
Okay.
Absolutely. Is this Albert? What is this? Your guy? Forget his name. Abram Schwartz.
Yeah,
Schwartz.
but I
Whatever.
know. But well, he's now associated with Tampa General, so he only comes in once a week. So I haven't seen him very much. I
So
have
who?
one of his assistants named Valerie Massimo or something like that.
Right.
Valerie.
And what sort of doctor is she?
She's not a doctor.
Oh, jeez.
Well, then, if she's not a doctor, don't take it. Don't take advice from her, and don't take the shot, Paul. You've got to do this with a doctor. This is why we're saying this to you. That's why she's putting you on, because again, these bloody, excuse me if I'm offending anybody, these physician's assistants and these nurse practitioners, they start giving advice at decision points. They are there if you're in a stable position, with certain exceptions with respect to Mark Valence, who happens to have a very good one, but 90% of the time, don't make a decision based on a nurse practitioner or a physician's assistant. Insist on talking to the GU medical oncologist or the radiation oncologist. Do not.
Okay. That's good advice.
Have you gotten the shot yet?
Yes, I got the shot a few days ago.
Ooh.
Don't get another shot. You're going to have to go with it for the 3 month. Was it a 3-month shot?
It's a 3-month shot, but she wants me to test my blood in 2 months.
Well, I mean, testing your blood doesn't matter. You've got to go in. You're going to have to let it run off so that your PSA comes up again, and then you're going to have to do a PSMA. What she did was wrong.
Unless he could get a scan this week.
Unless you could, yes.
Lupron might take a few days to drop. It's not like Orgovix or something.
Absolutely. If you call them up and tell them you want a PSMA immediately, that you feel it was bad advice, and before your PSA drops, you want another PSMA scan. You're going to have to advocate for yourself here.
He won't do it.
It's okay. I understand that. I think it might be safer to just not take another shot. Wait till the PSA comes back, and then do the PSMA scan. Then we can be sure.
You're going to be you're talking about 6 months.
Really?
You're talking about 6 months. Okay, I would say if it were me, I absolutely agree with Dr. John. I would get a PSMA this week before it drops your PSA. And it may not show anything, or it may. If it shows something, we come back and we can talk about it. And don't ever see a nurse practitioner or a physician's assistant if you are at a decision point. Insist on seeing the doctor.
Okay.
But don't push this. Don't push. I would not kick the can. Would you, John, Dr. John, or anybody else? Would you, if you could get a PSMA this week?
I'm so glad you jumped in and caught that, Rick.
Yeah, Rick, I agree. This is urgent. This is not something to wait months down the road.
Okay. I'll call them and tell them I want an immediate PSMA scan.
And if they say, well, it's too late, you say, no, it isn't, because there's a flare with the Lupron. It's going to drive my testosterone up before it drives it down. So you've got to be in a position to advocate for yourself. And I definitely want this. And if I don't get it, I'm going to make a stink that this PSMA should have been done before you gave me the Lupron shot. And put them on the defensive, because if you put them on the defensive, they'll agree with you. If you don't put them on the defensive, they'll push you off.
Okay. All right. All right. Thank you very much.
All right, Paul, good luck.
Okay,
And
there's an issue about what drug to take next. That study that was shown in the Lancet, that a phase 2 study that showed that you should take abiraterone before one of the lutamides.
Whoa, time out. Can we, Jeff, we don't have
Well, you
time
talked
right now.
about him.
We got a lot of people, and that doesn't matter to him right now. Next time it matters, please bring it up. Okay?
Yeah, you did discuss it. That's why I bring it up.
all right. Bob Pethtal.
Yes. Yes, actually, Bob is on the call, and we are going to tag team. Okay.
Go ahead. You run it.
Short history here. Bob came on with a Gleason of a 4-3 and a number of 3-3s, radiation and Orgovix, and he was told that he should go down to the low and intermediate group. Okay. So I have been assisting Bob on the VA side. I got a copy of his biopsy and I read it, and I want to read some things in there that might change people's mind. Okay, on the 4-3, it's a 60% pattern 4, but there is paraneural invasion is present. I'm not quite sure what that is, if it's bad or good. Additionally, another needle biopsy says a high-grade prostatic intra EPITHELIAL neoplasia.
Right.
I don't know if that's good or bad.
Both of those are not. Don't change any decisions.
Okay, now
neither of those change a decision.
Okay, now another thing. Okay, the pattern 4 in focal areas, cribriform. So, with those 3, does it change the decision or the path of radiation and then Orgovix for 6 months?
No.
Okay.
No. The cribriform. So the cribriform is tricky. All right.
Okay.
What we know from the cribriform, and I think Doug Bent was on the call before. I don't know if he still is, but what we know from the cribriform is that it gives rise to a Gleason 4. If you see cribriform, it's automatically considered to be a Gleason 4. And it is more likely that the cancer might return, but it does not change any treating protocols. And we've been through this in some detail. Myself, Mark Perlow, and somebody else, I can't think right now. But forgive me if I'm offending anybody who the other person was. But we've been talking about it at length, and there really is. It doesn't mean you have to do more radiation. It doesn't mean you have to do more hormone therapy. It just means that there's a greater likelihood that your disease might come back. So I would say Bob Pethtal belongs in the low intermediate, along with Dr. Mark, and none of those issues warrant him having to hear what's going on in this group.
Okay.
Now, if he has a recurrence, a rising PSA after this radiation therapy.
Okay, now the story was actually in 2014 he had cryo, and this is the 4-3 is a recurrence. So I don't know if that makes any difference.
I don't think so. Cryo was it like just spot treatment?
That I'm not quite sure, and he isn't either.
I mean, I would say that if it was cryo, the likelihood was that it was focal therapy. But he needs to know that because it changes the whole picture. He's got to go back and find out. But my guess is if it was cryo, it was focal. But cryo could have been used to treat the whole gland at the time. So if it was cryo and it was the whole gland that was treated, he now has a recurrence, and we should be treating him as a man who has recurrence. And then, yes, he does belong in this group. If it was focal, then at this point, he doesn't, I would say he's best in the low intermediate.
Okay, that's it.
Go ahead, Jeff, Marty.
Yeah, if that urology group I went to 2 weeks ago, if the cribriform is over 0.25 millimeters, it is much more aggressive. And they should find out whether or not the size is over 0.25 millimeters.
Yeah.
It's considerably aggressive.
It is more aggressive, but it doesn't change. Oh, it was Ben. Excuse me. And he'll listen to this. Oh, my gosh. Ben will be listening. It was Ben and Dr. Perlow. I'm sorry, Ben, when you listen to this. It was Ben and Dr. Perlow who did the research. And we referred Doug to Ben. And the criteria is, even if it's cribriform, even if it's of a certain size, it doesn't change the treatment, the recommended treatment. It just means that it's more likely. That's the conclusion we came to, but could be wrong. And I know that Jeff is watching out on Euro Today for that, so that we can all watch it when it's posted as a recording.
This is John. My notes from when he first came in early September was that it was whole gland cryo. So it's worth getting the operative report and seeing what they did.
Okay, no problem. Anyway, I will work with him because we are presently putting together a VA claim.
All right, thank you, Jim. Let's see. Richard Fisk, looks like we are getting to you, Richard. Go ahead.
Yes, sir. Got a marginally relevant question based on Rick's email, where he talked about using artificial intelligence to analyze initial scans and other information, and then to lay out a treatment plan from that. Is that going to be available for retrospective look? That is for someone who has completed treatment to look back, enter the initial data, and compare it to the treatment that was actually accomplished.
So Dr. Mark wrote wrote that post. I think he was referring to the Artera technology, which right now, as far as we know, is really to help men decide whether they should go on hormone therapy or not. I cannot tell you what else Artera offers, but you might want to go on the website and see if they do a retrospective. But I'm also not sure why you would want it.
Information only. That's all.
So, there's no point in getting or paying for a test, in our view, unless it changes your treatment plan. So it might be nice to know, but for information only, I don't know what it would do for you. I mean,
like I say, it would provide confirmation if nothing else. But this is not worth the time, so go ahead and move on to somebody else.
All right, Richard, thank you for that. And Al Latimer, I believe you are next.
Hi, everyone. I haven't been on this group in several months now, I guess. I've been busy with a lot of different things. We sold our house, we moved. I was in a clinical trial. Well, I'll just start where I am right now. I started Jevtana last Friday, and I'm wondering what kind of experience. I'm sure other people here have been on Jevtana, and I was wondering what kind of experience people have had with it in terms
Anyone
of,
here been on Jevtana?
side effects.
Cabazitaxel?
Cabazitaxel, yes.
It looks like no one
Okay,
here has
well,
been on it, but I can tell you
so
this, generally gentler than docetaxel. You get less peripheral neuropathy, less hair loss, less GI side effects. And I remember there was a study comparing, they put guys on docetaxel and cabazitaxel, and I think it was the crossover arm, and then they asked them which of the two drugs did they prefer, and the majority of them preferred cabazitaxel to docetaxel. So I think you've already done docetaxel, right?
I have.
You probably
Yeah,
find it easier to
2 years
tolerate.
ago.
Yeah,
So
you probably find it easier to tolerate cabazitaxel.
It seems to be that way so far, but it's kind of early to tell. I guess once I've had a couple doses, 2-3 doses, it might be clear as to where I stand. But yeah, I had a lot of problems. I had some problems with the docetaxel with fatigue and neuropathy. So anyway, I'm surprised no one. So am I at the cutting edge again?
No. I mean, it's just that cabazitaxel is predominantly was developed and approved as a second-line chemotherapy after docetaxel. It was approved plus or minus around 2012, 13, something like that. Now, what has happened since then is that there have been so many new drug approvals that when docetaxel fails one of these guys, they go through to another type of therapy. And so we tend to use cabazitaxel less often, or we use cabazitaxel as the first line instead of docetaxel, but a lot of docs aren't willing to do that. We like it because it has a lower side effect profile. But a lot of docs as a first line taxane are not willing to give cabazitaxel.
Yeah,
So
that was my situation when I started the docetaxel.
right.
But I didn't actually fail it in terms of it stopped working. I failed it because the side effects got to be too much.
Right. So, by the way, we don't think you ever fail something. It fails you.
Okay,
That's just an advocacy, a patient advocate lingo that we feel the drug fails
okay,
you. You don't fail the
okay,
drug.
okay. It failed. The drug did not fail me. It's just the
Well,
side effects got to be
the side
overwhelming.
effects were too heavy. Now, in all the years, I only remember one situation where a guy did have a real adverse response to the cabazitaxel and had to stop it. Most of the time, it has a fairly gentle side effect profile, and we've known people who have been on repeat cabazitaxel for a very long time, like 2 years or so. It's well tolerated.
Well, so I don't know. We'll see. My PSA is starting a lot higher than it was when I did the docetaxel. My PSA is about 250 right now, as opposed to before it was 60 something. But we'll see.
So I had a note here that your PSA when you stopped the trial was 262.
Okay, well, okay, so I rounded it off a little too much. That's correct. It was 262 when I stopped the trial. It has creeped up only a little bit since then. It's about I think it's 270 now. But anyway, 250, 270, same kind of thing.
Okay.
So I had so my most recent PSA test was last Friday when I started the cabazitaxel. So we'll see. Do I have another minute? I have a second thing I
Yeah, go
want to
ahead.
bring up.
Go ahead.
Has anyone here heard of extramammary Paget's disease? It is something that's supposedly can be associated with prostate cancer, and it's something that I was diagnosed with about 10 years ago. And now my brother, who also has prostate cancer, he has been diagnosed with it as well. It's a rash that typically shows up in your crotch and is typically misdiagnosed as just some kind of, I don't know, chafing or something that just kind of comes and goes. But it can get to be very serious if it's not treated. So I just want to say, if anybody's got a rash in their crotch, they should have it looked at and followed closely, because my brother's situation got to be pretty severe before the dermatologist decided to do a biopsy of it. So,
Dr. Jeff, were you seem to be nodding in acknowledgement that you know something about this?
Yeah, he correctly described it. It's a rash in the perianal or crural folds. You have to have a biopsy to diagnose it. It's a skin malignancy, and it's often mistaken for fungal infections, candidal infections, eczema, things like that. So he's right. You have to be aware, and you should see a dermatologist, and it should be treated. A lot of times it's treated with Mohs surgery, sometimes drugs like imiquimod, topically, 5-fluorouracil, things like that. But it is something to be aware of, and you should see a derm, not a general provider, to get it correctly diagnosed.
so it's a pretty rare disease, but the fact that my brother and I both got it and we both have prostate cancer, it just is just kind of, I don't know,
Well,
weird.
it's often seen in people who have cancer. So,
Right.
if you know you have a malignancy and then you get this rash, it should be, you pointed out perfectly, it should be a kind of a red light to go see the right
Well,
dermatologist.
that's why I brought it up, because I think everybody here has cancer.
Well, you're right. And if you get a rash, like you said, it's time to see a derm.
Yeah, and they need to biopsy it too, because lots of
Right,
times they will dismiss it as something else.
right.
And in my brother's case, it went on for years before they decided to biopsy it, and then it wasn't even the dermatologist that recommended it. So, watch out for those rashes. That was the other thing I wanted to bring up.
Okay, thanks, Al. Thomas Matica, you are up.
Okay, thank you very much. Well, I just wanted to get some comments. anything that you might say regarding I have a visit to OHSU genetics testing clinic, and yeah, it's called OHSU Medical Genetics, and they sent me a letter and a questionnaire with all the typical questions about family history and a little bit about my history, where I put in information about my condition, what drugs I'm being treated with, supplements, that sort of thing. But I just have a general question about what to expect from this genetic counseling session. When I hear that, like with the Promise trial, there may be some forms you have to fill out, but you just send the swab in and they give you the results. And I'm kind of thinking, well, why don't I just go in and get the test, get a test. I'm not sure which one between the germline and the somatic. I know the difference, but why not just go in and get the test? What is the counseling session all about? What's the what are they trying to do? Are they just trying to give me good advice?
Well, the counseling wouldn't come into play unless they found something with assuming you're talking about a germline test. If they come up with nothing, you don't need to be counseled.
Yeah,
not really, Len. Not
No?
really, because the standard of care in many places is that deciding to get a germline inherited test is a shared decision. And so the reason that why you see a genetic counselor in many places like Kaiser and other places is they want to tell you before you take the test, if it comes back bad, what the implications are, and do you still want to take the test? That's my understanding. Now, you don't really need the counseling session beforehand. You need a counseling session after if they find adverse results. The Promise trial has determined that you know enough in applying to them that you're willing, you've already made the decision you want to test. But the reason they're doing this is just to tell you what this inherited test is. It's not a somatic test. From my perspective, I would say don't waste your time. You might get a slightly better test. Just apply for the Promise. You haven't done the Promise test, correct, Thomas?
That's correct.
I wouldn't knock yourself out with all of this. Just sign up for the Promise test. They'll send you a swab. They'll check you for 32 instead of maybe 70 different inherited mutations, and the 32 most common. And if you don't have anything, you'll be just like Bill Yu, and you'll get a good. They'll say nothing there. And if you do, you'll get a test. So this is why we send people to the Promise test.
And what you're always talking too about this somatic test. How does the somatic test come into the big picture here?
So the somatic test tells you what mutations your own body has made, not what you've inherited. It's not what the genetic counselors are not in the field of somatic. They're in the field of inherited. And if your disease progresses, then it's very helpful to know what type of mutations your own body has made. But for where you are right now, where you're pretty stable on treatment, I'm not sure that you really need it. I just want to see. I can't remember. I'm just checking. What did your disease was recurrent, right, Thomas?
Yes.
And what sort of what did you have in the way of metastasis?
Well, I had a PSMA PET scan in August of 2023, and they found good sized metastases in my ilium and sacrum, and that's it. On that PET
Okay.
scan, nothing
So
else showed.
the bottom line there is they should have ordered a somatic test. That's the standard of care. When they found that, they were required by ASCO or NCCN, AUA to order a somatic test. Most doctors don't do it. They should do it. They should have also ordered a genetic test at the same time, probably subsequent to the somatic test if you had anything suspicious. So, do you need a somatic test right now? You're on the Firmagon and the darolutamide. Debatable. We're not going to be able to get it from your blood, I doubt. So it would mean finding a lesion that you still had, and it's something that should be discussed with your GU medonc, Alexander, whatever her name is.
Sokolova.
Sokola, but you went to her recently. You went to her after they found. She wasn't your doctor at the time they found these lesions, correct?
Correct.
So had she been your doctor, she probably would have ordered a somatic test. You can talk with her about the value right now. The inherited test is useful. I wouldn't knock yourself out with jumping through hoops at OHSU. I just do the promise test if it were me.
Okay. Yeah. See, they've. It's not going to cost me anything to do that. So it's on Wednesday. Maybe I'll go for it and do that one. But I guess it doesn't make much sense to do the promise test then if I do that.
No, but it costs you your time and having to go downtown and all of the rest of it. That's all it costs you.
Yeah. And this is, I suggested doing this. I just said, well, this is several months ago. Well, why don't we just do it? Just a kind of a very, casual sort of thing. And she says, okay, we'll do it. She'll make a referral. And that's why I'm doing it.
Okay, but the fact is Sokolova should have ordered it immediately.
Yeah.
When you came under her care.
Yeah. Okay, well, I'll keep that in mind, and it's good you say that. So, all right, well, that's good enough for me. Wait,
in the presentation this morning, the point was made that any man who has probably every man, in fact, what he said is every man should have a germline test, the urologist, but certainly anybody who has recurrence.
Yeah. And just as a reminder, I think there was one of these genetic testing services that you recommended against. I know the promise, Decipher is okay, the Decipher trial, but there were a couple of other ones mentioned. I think a Tempest and Boston.
So again, we don't need to go there right now. Decipher is something completely different.
Okay.
Okay. And those are in the context of somatic, and we're not talking somatic. So I just want to try and stick on where we are. And we are talking about getting a inherited test. You can get that from Myriad. But it will cost you. You can get it through OHSU. They do it themselves up there. You can get it from Illumina. I think it's Illumina or one of the ones with an I. There's a whole bunch of places you can get it. But we usually send people to Promise because it's easy and simple. And Myriad isn't happy with us about that. But it's just convenient and easy, and you don't have to go anywhere to get the result.
Yeah. Okay. All right. Well, good. That's all I need.
Jim Marshall, did you want to add anything to that?
3 quick points on the germline. Provided you do have a germline, they then cannot deny you care or medical care. Number 2, if you do have germline, you must disclose at the time that you apply for life insurance or long-term care. That is a mandate. If you don't do that, you're in trouble.
Okay.
Gentlemen, we are ready to wrap it up. Anybody else wanted to comment before we close it? I think I got to everyone.
We could go
Jack?
back.
Go ahead, Jack.
I just want to tell you all, I watched the PCF immunotherapy thing prior to coming. That's the reason I ran late. It was fantastic. Okay, so I know you're going to watch the recording. They had a fantastic study of a patient. Agarwal, all those guys were great. You recommended it. I loved it. It was great. It taught me a lot of things you've been talking about DLL and everything else. And it was very interesting. So,
yeah,
I second that.
You watched
All right.
it? Okay.
I second that.
Yeah, thank you guys. Very good. I definitely want to see it on the recording.
Yeah, I was planning on watching it on the recording. I do want to go back very quickly because we cut off Jeff Marchi for time. Jeff, you want to talk about that second line ARSI at this point?
Yeah, I could discuss it. There was a study that the Lancet put out that talked about the fact that people should be doing abiraterone first and one of the lutamides second. That is the best result. The thing is, if you've got heart problems, you really may not want to do abiraterone because it is really hard on your heart. But they found that that sequence of abiraterone and then lutamide gave you the longest life. And I know for me, I was on Abi for 2.5 years. I mean, Jim Marshall for 5, and I moved to darolutamide, and it's given me a full year of undetectable. Abiraterone never did that, but the sequence worked for me. It is recommended in the study that they did that the Lancet reported. So that essentially is it. You just have to worry about the heart issues.
Right. So that's what we always say here. You do abiraterone first. Len, this is you probably can even cite the article in the Lancet.
Yeah. We've known about this for years. However, I may be in a minority. My recollection is that the advantage of sequencing Abi first and then a second ARPI is not huge, but it is the best sequence to follow. Jeff, I wanted to ask you, did you stop Abi because you were no longer responding to it, or just
No,
decided?
it's because of the heart issues. I was in the
So
hospital
you were
for
still
4 days with
responding.
AFib. Yeah, it's my oncologist says no more Abi. So
Okay.
The numbers, as I recall them, and Len can correct me, is that abiraterone after one of the Ide brothers at the time, it was just enzalutamide or apalutamide, about 8% of people had a response. Whereas if you reversed it and did the Ides after the abiraterone, it was around a 30% response.
Yeah, that's about right, Rick. But I think the duration of that response of the second ARPI wasn't terribly long. But anyway, in Jeff's case, it's a different case because he didn't start a second receptor blocker because he failed.
Right.
Abiraterone failed him. But the study pertained to patients who failed the first treatment and then went on to a second. Yeah, I'll try and find that reference. I'll mail it to you, Rick.
Was there a problem moving from lutamide to the abi? You said only an 8%. What did you mean by 8%?
The people who moved from an IDE, enzalutamide or apalutamide, to abiraterone, only around 8% got a response.
A better response. Okay. Okay.
Yeah, and the others, the abiraterone failed them. So they didn't get any mileage out of going to the second line, switching to a different second line anti-androgen.
Yeah.
That's
Which
good
is
to know.
why there's been a lot of criticism about clinical trials that are run using a second ARPI as a control arm, because it's not it's not very effective anyway.
Right.
It's more like a placebo.
Right. Exactly. And that's why the drug of choice, when you go onto a second line anti-androgen, unless you have comorbidities like heart issues, is abiraterone before the IDEs.
Right.
Jim, you still have something you'd like to add to that?
Yes, alert the new people. If you are a veteran, there will be the veteran support group is online tomorrow night live from the Shemer room. So
No.
8 o'clock at night. And so I don't know if the new folks are vets, but if you are, come and join us, please.
Yes. And it's the Schmear room, but you were close.
Schmear. Okay. I have to get the pronunciation correct.
You were very close. Schmear, not Shima. But
Oh,
you were, yes, Schmear. But you were right there in the ballpark, Captain Jim. And yes, if anybody here is a vet and hasn't attended that group, boy, there's so much that you can benefit from that group.
Like money.
Like money. That's right.
You are entitled to a lot of money and potentially free VA health care. That's a new thing, which we will talk about.
And let me just say, not only do we have Captain Jim, who is amazing when it comes to quoting the alphabet soup, but we have Sylvester, who worked in the system for 39 years. Right, Sylvester? 39. I think I got that right. And worked in the VA. We've got Dr. John, who often comes, who worked in the system the whole of his working career as a pain and addiction psychiatrist. So we have a lot of inside tracks when it comes to navigating you to get your best health care and to get your best, and it's disease agnostic, to get your best benefits in healthcare. It's disease agnostic. We do not talk really about treatment details. We just try to make sure you're getting the best treatment. And if you've got any friends who are vets, send them along. Right, Captain?
Absolutely.
Would you give me the site again?
Okay.
Okay, I put my email address and the phone number in the chat. Do you see it?
Right at the bottom. Send Captain Jim. I tell you what I'll do. Better than that, send Captain Jim a note. And Luther, I've got your email address. I'll send you the reminder that went out this morning and forwarded it to you. It's not in this room. It's in our other room. I'll take care of it right now. I'll send it to you right now.
Hey, Rick, I never even asked you this question before, but before I end the session, should I stop the recording or it doesn't matter?
You don't have to. You can just, as long as you close the meeting out.
Okay. And I am
I
ready
want
to
to
do that.
say one thing before we end. Can I say one more thing, just very quickly?
Go ahead.
Take the survey, because if you don't, Rick is going to set your car on fire. The choice is yours. Just
Yeah.
public service announcement. That's it.
He's a
I'm out.
501c terrorist.
Never out of practice.
Oh my
Easy as
gosh.
that.
You could have said, hey, you could have said that whilst my board member was still on, but no, you wait until Muslin goes and then you say it, you know?
I'll tell him myself. He's already done it, hopefully.
Okay.
It's easy. It's easy. It's not a long process. Do it.
All right.
Thank
Thank
you.
you, gentlemen. Thank you for all your participation. We'll see you next week. Ciao, ciao.
Good night.
Good night.
Good night, good night, good night.